Good afternoon, everyone. So the topic of my presentation is ocular hypertension, the way forward. Ocular hypertension is defined as intraocular pressure more than 2 standard deviations from the mean of a normal adult population with normal visual fields and no evidence of glaucomatous optic disc changes. But studies differ in their definitions of what is normal visual fields and normal optic disc structure. The management of OHT, we all should understand that it's not simple because ultimately it's only a subset of patients who will develop visual field abnormalities. The average monthly cost of glaucoma medication, the risks of adverse effects with therapy, the inconvenience of topical medications, and the incidence of non-compliance, these are enough justification not to treat OHT indiscriminately. So we need to have a thorough understanding of the evidence-based risk factors. Which are the risk factors which play a role in decision whether or not to treat a patient with OHT? How do you synthesize a patient's risk factor profile into a recommendation for treatment? And does delaying the treatment of OHT matter? So these questions were answered by the OATS trial, one of the landmark multicentric trials, and it was conducted in 3 phases. The OATS 1 phase was just a proof of concept. This was to identify whether early treatment reduces the risk of conversion of OHT to POAG. And in OHT 2, it was to determine when treatment should be initiated. And the OATS 3 was to determine the incidence and severity of POAG in the cohort and to develop a 20-year prediction model. The results of the OATS 1 study has clearly shown that topical medications reduce the progression of OHT to POAG from 9.5% in untreated subjects to 4.4% in the treated subjects over a period of 5 years. And they also identified 5 important risk factors like increased age, high baseline intraocular pressure, high vertical cup disc ratio, greater PSD, and thinner CCT. In the OATS 2 study, actually in the OATS 1 was conducted over a period of 7.5 years with a treated arm and untreated arm. And after 7.5 years, the phase 2 OATS study was conducted where the treated patients were continued on treatment and the patients in the untreated arm were started on treatment. So, it was found that POAG development after 13 years was 0.22 in the untreated cohort compared to 0.16 in the treated, in the treated cohort. And the absolute effect was greatest for the high-risk OHT. And in the study, we all know that CCT was a very strong predictive factor. A CCT less than 555 microns had a 3.4 greater risk of progression to POAG. But how does this translate to the Indian scenario where in the Indian population the average corneal CCT ranges between 520 to 540 microns? And there's another statistic that is used in these studies, and especially in the OATS, it makes sense. So that's the number needed to treat. So the number needed to treat was, calculations show that for every patient that is prevented from developing glaucoma, 20 patients with OHT will have to be treated. And this number, Cass and colleagues had stratified based on the risk profile. And in low risk OHT, this number needed to treat was 98. In moderate risk, it was 16. And in the high risk, the NNT was 7. There's another study, European Glaucoma Prevention Study, EGPS, which was conducted around the same time as OATS 1, and this also showed similar results. So where do we start? So the risk calculators is a good starting point. So this actually gives the 5-year likelihood of conversion of OHT to glaucoma based on the 5 important risk factors. And this gives the 5-year risk of developing POAG if it is more than 35%, then you can treat the patient. This calculator has reasonable accuracy in distinguishing high and low risk OHT profile. But a word of caution, this risk calculator will be more accurate in patients who resemble the participants of OATS. This is the risk calculator, the scoring tool for assessing risk 2. This is a handheld calculator where you put in all the information of the patient, and then you get the probability of conversion over the next 5 years. And if this exceeds 35%, then you can start the patient on treatment. So if this is not available, then the online calculator is there, so based on which you can calculate the risk. A very important drawback of the OATS study is some of the important risk factors which we all know, like myopia, race, cardiovascular disease, family history of glaucoma, diabetes, which have high risk for developing glaucoma. These were not found to be risk factors in the OATS trial, and especially diabetes, it showed very inconclusive, there was no definitive answer. So there were other studies which were conducted, especially there were cost effectiveness model studies from the United Kingdom and the Netherlands, and they actually incorporated even SLT as a treatment modality in OATS for ocular hypertension. So where do we now move? So the way forward, what is it? So the approach to management should be based on whether they are high risk, moderate risk, or low risk. If the intraocular pressure is more than 30 millimeter mercury, then you need to treat the patient, whether, regardless of whether the cup disc ratio is less or CCT is more. So if the IOP is more than 30, you have to treat. If the IOP is about, it's 26 or more, and the CCT is less, or if the cup disc ratio is 0.4 and CCT is less with RNFL and PPA changes, there again, treatment is offered. In moderate risk, that is between 24 to 29 mm mercury without NFL defects, or between 22 to 25 or more with CCT less than, with thin CCT, or 0.4 or more and CCT is thicker, and with history of family, a positive family history or high myopia, there you can consider not to treat the patient but monitor them. And if you see progression, then you can treat. In low risk group, when the pressure ranges between it's above borderline 22 to 23 and CCT is normal or high, or just 0.4 cup, in those cases no treatment is given, and you just have to monitor once in 2 years. The target IOP, when we decide on treatment, a reasonable aim is to have a 20% reduction. So when considering treatment, clinicians must weigh the known risk factors, the life expectancy of the patient, the quality of life issues, and the patient's desire for therapy. So ultimately, the decision whether to initiate treatment or not for a patient with OHT is the patient's. The patient has to decide. So we need to have more pragmatic RCTs and cost effectiveness studies to understand the to have better data and to decide on the management of OHT. Thank you.
Thank you very much, Subashini madam, for giving a in